Okay, we're going to go ahead and get started. Good afternoon, everyone, and welcome to our monthly School Health Services Multidisciplinary Information Session. I am Mary Cruz Lopez, Community Engagement Specialist with Nevada Health Authority, and I'm really glad you guys could be here today. I want to note that today's session is being recorded and will be posted on our website. Please feel free to ask questions as we go, and then just raise your hand or enter any questions onto the chat. Today, we are learning about leveraging MTSS to achieve comprehensive school mental health systems with Dr. Ashley Greenwald. This session will explain how MTSS core features align with the National Center for School Mental Health framework and will include Nevada-specific examples to illustrate each component. Dr. Greenwald brings extensive experience in partnering with districts, state agencies to strengthen behavioral, academic, and mental health supports for students. We're excited to have her guide this session as we explore how MTSS can support comprehensive school mental health systems in Nevada. Now we'll go ahead and pass it off to Dr. Ashley to start.
Thank you, Mar Cruz. Welcome, everybody. Good afternoon. I'm happy to spend a little bit of time with all of you today. I know most of you on this call, so it's lovely to see my friends here. Thank you for being here. We are a really small group, so I would love if you would just ask questions as we go. I have a set of slides, but we can follow along with those. We can have some conversation on the side. So feel free to chime in if you've got a thought that you'd like to share or a question or a wondering. That would be great. So I will go ahead and share my screen. And just so you know, I may not be able to see you raise your hand while I have my slides in presentation mode. So if there's something that you'd like to say, just please interrupt me. I take no offense to that. I would love it. So let me go ahead and get my screen up here. Okay. All right, can you all see this okay? You see it in slideshow mode? Wonderful. Okay, yep. Thank you. All right. Okay, so let's talk about how we might use MTSS for comprehensive school mental health. So, a lot of you on the call are familiar with MTSS, and so familiar that perhaps you have just as much experience as I do inside of the implementation of MTSS at the local level. So I'm very grateful to have really wonderful colleagues on the call. But when we talk about MTSS, we're talking about a prevention framework to organize the level of the school building to address the individual student needs. And when we talk about what those needs are, we're really talking about a whole child approach. So a very holistic approach, which includes academic practices, behavioral practices, and social, emotional, or mental health practices. And that allows us to really support the whole child. And one thing I would like to really emphasize is that MTSS is an operating system. So I'm just going to spend a couple of slides orienting us just to MTSS, maybe just a few minutes, and then we're going to really dive into what it means for school mental health. So when we talk about MTSS, it's not a program, it's not a practice. It is an operating system or a framework. And what I mean by that is that MTSS has sort of three core components, which are data, systems, and practices. And the data are used to support decision making, so not for compliance, but for decision making purposes. The practices are ultimately what supports the students. And then the systems that we create supports the adults inside of the buildings. And of course, we are, looking at those three things with respect to outcomes, both academic and social, emotional, behavioral. Okay, so when I talk about MTSS, and I see some of you from the state are on, and some of you from the districts are on, and there may be some folks from school buildings on as well. There's really like sort of different layers and levels of MTSS because what the system looks like at the level of the state or the state educational agency is different from what it looks like at the local level, the local educational agency or the school district, which is different from what MTSS looks like in a school building, which is different from what it looks like inside of a classroom. So when we talk about MTSS, I am going to talk about a few of the different layers and levels just to provide a little bit of additional context. When we first started this work, we really started this work in like 2014. We were able to start publishing some documents about what this framework really looks like and means for the state of Nevada. And these are the two published documents, and they are endorsed and published by the Nevada Department of Education. So the first one was published in 2018. The second one was in 2022. The first one really defines MTSS, and the second one really talks about how to implement it. So we're going to pull a lot of resources from those documents today, but of course, there's no good MTSS presentation without a good pyramid. And so we, of course, have our triangle of supports. But one of the things that I really want to um, sort of direct your attention to is the words on the right of this graphic. So when we think about MTSS, a lot of people instantly jump to a hierarchy of supports, right? Or a tiered continuum of supports. So schools will often say, oh, yes, of course, we do MTSS. We have tier 1 practices and tier 2 practices and tier 3 practices. That's fantastic. I would not doubt that at this point in education, that majority, if not all schools, have sort of this pyramid of supports. That's fantastic. But that is just one of 7 core features of MTSS. That is really, really important to know. And it's often a misconception that people have when they talk about MTSS. They think it's just the triangle of supports, and it's not. MTSS is teaming at the universal level, at the advanced tier levels. It's problem solving, data decision making with leadership overseeing that process. It's using systemic implementation to identify and implement practices and progress monitor the effectiveness of those practices. It's screening for students both at the universal and targeted levels. It's the adoption of evidence-based interventions, and it's the use of high-quality instructional practices. And all of that together makes MTSS. And when we talk about MTSS, we're talking about academic, social, emotional, and behavioral. And just in case you're not familiar with this, the universal level is for all students. So it's the entire student body receives tier 1 supports and interventions and practices. So whatever your tier 1 looks like, it should be for all of your students. Tier 2 means a targeted at-risk population. So a smaller group of students who have been identified as maybe needing some additional supports. It's still a tier of prevention. So tier 1 and tier 2 are our prevention tiers. Tier 3 is what's more so considered a treatment or intensive intervention tier, meaning that we need individualized student interventions. And that should be a very small subset of students inside of a school. Um, One thing that people often ask me, they say, "Oh, well, Ashley, this makes a lot of sense for the younger kids because we can put in really great, cute, social, emotional curriculum, and that's all well and good, but this is never going to work for the high schoolers." Let me tell you that nationally, we've got lots and lots and lots of high schools that are doing this. Inside of our own state, we have many high schools that are doing this, and we also have alternative education sites, including our state-run correctional facilities, doing this work. So the intensity of the population and the needs of the population will change what your tier 1 practices look like. And that's an important message for everybody to understand. Okay, where is this work happening in the state? It's happening almost everywhere, which is really exciting. We've got several districts who have been implementing with us for a long time, some of them 10 years. We have several districts who are implementing with us for 3 or 4 years. We have several districts that are brand new to implementation with us. And we have one district that's shaded, Elko, we're just starting to discuss partnership opportunities and agreements with. So this is where the work is happening. We do also include work with State Public Charter School Authority inside of our partnership districts. So you can see that, a lot of great work is lifting up in Nevada, and we're very excited about it. I wanted to throw this one slide in here. I sprinkled a little bit of data in to keep it interesting for folks who maybe see me present all too often, and then also just for like the greater knowledge of the group here. But I wanted to share, this is a survey to our district community leadership teams, and I'll talk a little bit more about that in a moment. But I wanted to show you some of the outcomes that the district leadership members, so these are going to be district cabinet members primarily, are reporting as a result of their work in MTSS. And for the purposes of today, what I really want to draw our attention to is if we kind of glance down, we take a look at the use of evidence-based practices, the use of opioid abuse prevention and mitigation strategies, and the integration of school mental health services. So I wanted you to see those sort of three categories in particular because we're really starting to make some impact inside of those spaces. You can see that dark blue line is significant impact. The medium blue line is a moderate impact, right? So in almost all three of those domains, most everybody is responding that this initiative has had some impact in use of evidence-based practices, substance misuse, mental health, right? That's a really good thing to see. The other thing I wanted to show you is that across every single domain of student behavior that's reported in the reported as a result of the Nevada revised statute and reported by the Nevada report card, we see that our schools that implement with higher fidelity outperform the schools that have lower fidelity inside of our metrics when it comes to these behavioral incidents. And if you take a look at the areas where there are asterisks, those are the areas where we have statistically significant outcomes. So across almost all of our bullying, cyberbullying, racial discrimination, use of alcohol and controlled substances on campus, the schools that are using MTSS frameworks are outperforming those that are not doing the work as well. So that's a really good thing to see. I also want to show that the schools that are implementing this work are improving in all of their areas on the school climate, Nevada School Climate Survey data. So this is also really good to see that we're seeing really nice gains. We're seeing reductions in behaviors. We're seeing improvement in school climate. And all of that relates to mental health, right? Those are some of probably the most important components of creating safe environments inside of schools where children want to come, where children feel safe, and where children thrive. And especially, those of us who are, mental health clinicians, and I see several friends who I know are mental health clinicians on the call. You think about youth who have been exposed to trauma. And if you have been exposed to trauma, having a safe and consistent environment where you have predictability and adult relationships can be really, really important protective factors. So these are, creating those environments are very important. So why is it recommended to use MTSS to sort of lift up a comprehensive school mental health system? And I will share this with you. So the National Center for School Mental Health has sort of 8 recommendations, which would comprise a comprehensive school behavioral health system. And the first one is making sure that we've got this instructionalized support personnel, right? We want to make sure that we have all of the right people inside of the building. Workforce capacity is a big one. The second one is making sure that we've got families and schools partnered and collaborating and teaming together. The third one is that we have needs assessments and resource mappings. The fourth is MTSS. Okay, so MTSS is just one of the core components of a behavioral health system. We have to have mental health screening, evidence-based practices, data, and funding is the big one, right? Number 8, and that's a sore spot for many, I know. But what I want to say is that MTSS, if you think about MTSS as just a hierarchy of supports, that fits here well. But MTSS also comprises the family school partnerships and the teaming. It comprises the screening. It also includes the evidence-based practices. It talks about how to collect data, progress monitor. So there's a lot of these components that even though it's not explicitly sort of under the branch of MTSS in this diagram, that MTSS really hits on. And I'm going to talk us through some of that. So the state, our own state, has adopted MTSS as the framework for school-based behavioral health in Nevada. And there's a couple of guidance documents and white papers that have been published on this over the years. And what does this mean? So you'll hear us talk about interconnected systems or an interconnected systems framework, or some of you may hear the acronym ISF. I see that my colleague Dana Robinson is on the call. She is our ISF coordinator for the state. So when you hear her title, now you know it means Interconnected Systems Framework. And if you're wondering, what the heck is that? What we talk about is integrating mental health into the sort of existing educational structures that are built up through MTSS. So what this means is that we talk about how to identify students that have mental health needs, how to make sure that students gain access to evidence-based practices, how to use data to make sure that the practices are effective, how to make sure that we have clinicians that are able to support school personnel and students across the tiers, and how to make sure that we're creating healthy environments. And really some of the key messages inside of ISF is that there's one system of delivery, that the school has one system of supports, and it's a comprehensive support system for their students. Access is not enough. This is a really important one. So in sort of a traditional mental health and school partnership, it may be that someone from the school makes a referral to a community provider, and then, they check a box and say, yep, we made a referral. We know that kid is struggling. We did our job. We made a referral. Inside of an ISF model, it's really a much more collaborative model and a teaming decision where the community provider becomes part of the operations of the school. And maybe they are school-based clinicians, or maybe they are community-based clinicians that have memorandums of understanding or agreement with school providers, but there's some type of agreement and infrastructure in place such that the clinician is not only supporting the youth themselves or the student, but they're also supporting the classroom teachers that support those youth, that they also have the opportunity to communicate with those teachers, with the providers, with the special educators around how to best support this student, maybe also how to support a large portion of students inside of the population of a school. That lends well to the next idea, which is that mental health is for all, right? When we talk about who needs mental health services, it's everybody. Everybody inside of a school building, including the educators, need to have their mental health supported. We all have fluctuating mental health needs, and making sure that we've got good preventative practices in place, fostering those really, positive relationships, safe environments. Connectedness is really important. Belongingness is important. So how do we create that inside of a school building? And then, all of that, making sure that we've got that framework and those core components of the framework in place to make sure that all these nice practices that we put in place are working as best as possible. Okay, so remember I told you that it's different. MTSS is different at the level of the state, level of the district, and level of the school. We're going to dial down to the school right now. So kind of put on your school hat, and I'm going to share with you what MTSS would look like at a school and what it will look like for a student. So when we talk about MTSS at a level of a school, we're going to put some really robust Tier 1 practices into place. Now, the selection of Tier 1 practices is going to be informed by data. So making sure that the school has data, could be community data, could be YRBS data, or the Youth Risk Behavior Survey, could be school climate data that we're using. It might be maybe we already have universal screening in place at this school. We might be able to use our universal screeners to determine what are the needs of the student body, but identifying those needs and putting those good preventative practices in place at Tier 1, that's what we're going to start with. Once we have that in place, we're going to identify universal screeners, we're going to triangulate multiple sources of data, and we're going to have referral forms. So referrals can come from educators, students, family members. So we're going to triangulate multiple sources of data, and that will help us to identify students who maybe need additional levels of support. So instead of waiting for crisis, we are going to identify students early. Once we identify those students, we're going to make sure that we've got advanced tier interventions. We'll talk about all of these too. I'll show you examples. We're going to have advanced tier interventions, and then we're going to put those students into those advanced tier interventions. There will be a team in place that will help to review and collect social validity data. Did the student like this intervention? Did the family think this was helpful? Did the teacher think this was helpful? They will review fidelity data. Did the intervention get implemented as it was intended to? And they will also be able to progress monitor the student on the specific skills that we're trying to work on. All of that to say is that if the student is improving, fantastic. We don't need to do anything different. We can maybe exit them from that intervention. If the student is not improving over a set period of time, they might need a further assessment, and that will enter them into opportunity to receive tier 3 interventions. And we will do the same cycle at tier 3, social validity, fidelity, and progress monitoring. So it's a continuous cycle for improvement, and we're constantly using data to help adjust. Now, let me give you an example of what this looks like, because sometimes it's a little heady, it's a little theoretical, or philosophy heavy. So let's talk about a 7th grade student. We're going to say that this student attends a school that has a really great tier 1 in place, right? They've got academics, they have behavior supports, but this student has still presented with low self-esteem, does not have a lot of social relationships, and he is failing several classes. So the universal screener that's used at this particular school indicates a moderate risk status. Additionally, his academic scores have been trending down. So the tier 1 team that reviews all of the data for the universal screeners is going to flag this student because we have multiple sources of data identifying risk at this point. So this student gets a flag. That flag puts them to the tier 2-3 team. This school has a tier 2-3 team. Some really large schools have a tier 2 team and a separate tier 3 team. This school has a combined advanced tier team. They are going to take a look at all of the different data that this student has. So they're going to look at maybe some of his attendance data. They're going to look to see if he has any referrals. They're going to look at behavior and office discipline referrals, right? They're going to take a look at all of these sources of data. And they have determined that they're going to admit this student to tier 2 supports for academics and behavior. And so the tier 2 assessments are conducted, and they have decided that this student is going to have some increased time in core math. This student is going to receive an evidence-based intervention for tier 2, which is called check-in, check-out. It's a behavioral intervention that allows students to sort of self-monitor on a subset of expected skills that they need to engage in during the school day. And the student is also going to receive an intervention called CBITS, which is cognitive behavior interventions for trauma in schools. So 3 interventions have been selected. We're going to have the math curriculum during advisory period. The daily check-in, check-out will be with the school counselor, and a weekly CBITS group will be held with the school psychologist. The fidelity and the outcome data are collected. It's predetermined what data will be collected inside of those interventions, and then the tier 2-3 team is going to review those data every month. The dosage of the intervention can be increased or decreased as indicated by the data. So for example, if the student is checking in with the school counselor once a day, which is what was initially prescribed, see the daily check-in, check-out, perhaps that dosage may need to be increased to every other hour, right? It's possible. We don't know yet, but the data will let us know. After 5 months at tier 2, the data demonstrate an improvement in academics. Perfect, right? The math has increased, but the emotional well-being has not improved. The student is referred to tier 3 behavior support, and a community mental health provider is leveraged to do a tier 3 assessment and also to provide some advanced tier interventions. So that's sort of what the process of MTSS looks like. Now, let's get into some of those core components that we were talking about. So what is screening inside of MTSS and inside of this school-based behavioral health framework that we're talking about? So when we talk about screeners, there's sort of 2 screeners. I'll start with universal. When we talk about universal screeners, this is administered to an entire student body with the purpose of identifying general risks. So the universal screening data helps us with 2 things. It will help us to understand maybe what the entire student body is struggling with, right? Because maybe, as we all know, mental health needs are increasing nationally. Maybe the whole student population could benefit from some type of mental health literacy or social emotional learning curriculum. It will also help to identify students that may need additional supports. Now, just because a student screens or flags on a universal screener does not indicate that they need individualized intervention. It does not indicate that they have a mental health diagnosis. It's a universal screener that is one source of data, just like academic data, just like a behavior referral, just like office discipline referrals, that would indicate maybe this student is at risk. Okay, so we're going to need to triangulate those sources of data. But it is going to look for those risk factors. And most screeners are going to be looking at internalizing behaviors and externalizing behaviors. And oftentimes, as inside of education, sometimes we miss the opportunity to intervene on the internalizers or the students who have internalizing behaviors, because they're not making a fuss in the classroom, right? They're not the ones who are storming out and using curse words or throwing pencils and whatnot, right? Those are our externalizers. But this gives us an opportunity to look at them equally. And then it's administered to everybody. It does not require consent because it's observational in nature, meaning that there's no specific questions asked to the students about their health. It's just an observation of their well-being. Some schools will use blanket consent forms inside of like welcome and registration packets. Sometimes you can use opt-out. It's really up to the school board, but it generally does not require consent. Alternatively, a targeted screener. So a targeted screener is one that would be used sort of a level up. So when a student pops out in a universal screener and maybe has some other areas that are showing risk, you may want to do an additional level or layer of screening. And so this is used for targeted students to identify targeted risks. And so, for example, we might identify trauma. Really, the purpose of the targeted screener is to help us identify what intervention would be the most appropriate for this specific student. This absolutely does require consent. So this is going to be asking a whole lot of personal information of the student, which would require parental consent. Okay. Here's just an example of some screeners that some of our schools across the state are using, a description of the screener. So, when you're thinking about selecting a screener, you want to consider, who the screener is for, what the target population is, how long it takes to administer the screener, who administers the screener. You also want to think about cost, right? Making sure that it's sustainable, because sometimes, if you got a lot of grant funding one year in your district and you select a screener that costs a whole lot of money, can you maintain that? If you build that into your infrastructure, can you maintain that for years to come? So those are all considerations when adopting screeners. If you're interested, there's some really, really great guidance documents on universal screening that I'd be happy to share, that we just did a really nice webinar series on. Just as an example, in our own state, here are 3 districts who've been working on lifting up universal screening over the last couple of years. These data, they're a little funny because this is for a fiscal report or a federal fiscal report, but they're aggregated by quarter. That's what the Q1, Q2, Q3, 4 is. The Q4 is the summer months, so we don't anticipate any screening happening over the summer. But if you take a look just at District A, you can see over the few years, we've been able to really increase the use of universal screeners. In District B, this district had no universal screening in place and now has lots of universal screening in place. And in District C, again, we had pretty low rates of universal screening, and now, well over 80% of the student body is being screened universally. So that's really exciting to see. Best practice in universal screening is recommended to screen students 3 times per year for the entire student body. Now, is that always feasible? No. Is it possible? Yes. And some of these districts are already doing it. So that is really great to see, because if we don't know that we have a problem, we can't do anything about it. And again, this is as preventative in nature. Okay, so now let's talk about interventions. So we've got sort of 2 types of interventions. We have non-clinical interventions and clinical interventions. Now, something that's important to know is that oftentimes when we work with schools and districts, we will go in and say, okay, well, what interventions do you have for mental health? And they say, oh, well, we have the school counselor. Great. That is a person. That's not an intervention, right? We want to know what the interventions are, and then we also want to think about who can deliver them. So when we talk about non-clinical interventionists, these are the people, right? The people that deliver the intervention. These people typically work primarily at tier 2. So again, this is a preventative intervention. It's for an at-risk population. These people might be school counselors, school nurses, school social workers, behavior specialists, special educators, peer specialists, behavioral health workers, right? There's a whole lot of people that can engage in non-clinical interventions. Here's some examples of some tier 2 interventions. Some of these are a little bit more clinical in nature. So especially CBITS is a little bit more clinical in nature. You might want to have a licensed clinician even at a tier 2 level. But some of these, like bounce back, do not require some of the clinical supports that some of the others do. So there's some opportunities, and then some of them also have companion guides for cultural considerations. This one in particular for Native Americans, which is really nice, especially in Nevada. We have a large population of Native American youth. Okay, here's some more examples of Tier 2 Resilience Education Program, REP. It's pretty popular lately amongst our schools and districts. All right, now when we talk about Tier 3, these are going to be primarily clinical interventions, but in a similar fashion to Tier 2, not always, right? So we may have some sort of like cross population of the WHO, but Tier 3 is typically delivered by a licensed behavioral health professional. So might be licensed mental health clinicians, licensed clinical social workers, school psychologists, licensed behavior analysts. So these are some sample interventions at Tier 3, acceptance commitment therapy, cognitive behavior therapy, dialectical behavior therapy, functional behavior assessment, right? These wraparound, these are some of our Tier 3 interventions. And one thing that I want to talk about, I'm not going to spend a whole lot of time on interventions today, obviously. We've just got a brief time together, but I do want to share that when we work with our schools and districts, part of MTSS is creating data decision rules and progress monitoring sort of boundaries, if you will. So what does it mean to engage in a curriculum like bounce back? Let's take that for an example. Okay, so bounce back is appropriate for ages 5 to 11. And then what we do with the bounce back is what we want to know, right? So we want to make sure that we've got 10 sessions in a group format per the curriculum. We're going to be focusing on teaching coping skills and healing. There's a bounce back manual, right, that we're going to use. So how does a student get into bounce back? And that's a really important thing for a school to iron out, because it would be very easy to say, you know, oh, I got a teacher referral today. This student was having a hard day. We're going to put them into bounce back, right? But we want to avoid that, because what ends up happening is that we then get very top heavy in our interventions. I mean, it could be that all students all of a sudden start rising into the bounce back group. So we don't want that to happen. If we have a really strong universal need for a specific, you know, coping skills, maybe there's some other really good tier 1 interventions around coping that we can put in place, but it doesn't need to be an advanced tier intervention. Okay, so we want to have really good criteria for how to get into an intervention. So as an example, this one is talking about, you know, we want to make sure that we've got a high or moderate risk on a universal screener. We've got safe voice tips, handle with care tips, or family teacher referral. And we have, you know, high risk identified through a targeted screener. Okay, so that's going to be our entry criteria. How do we monitor the progress? Weekly progress reports. And then how are we going to make sure that a student has the opportunity to get out of the intervention? How will we know when we've been successful? Or if this is not working, we're looking for either a reduction in the risk on the trauma-specific supplemental screening tools that we're using, or an increase in the use of the skills as measured in the weekly progress report, right? And if the team reviews this progress and after the 10 sessions decides that this is not working, that's another reason to exit the student from this intervention, okay? So students should not stay in interventions indefinitely. All right, let's take a look at some mental health services data. So these are the same districts that we were looking at in the last data set. And you can see just sort of like a, you know, a nice slow increase. It's progress. We've got the percent of students across the districts per quarter, but these are the percent of students that are receiving interventions, mental health interventions. So, you know, there's no magic right number. You can see there's some discrepancy and differentiation between the districts. District A and is probably the highest, District B in the middle, District C has the lowest percentage of students receiving interventions. There's some published literature on sort of what the expected rate of delivery of mental health interventions could be inside of schools, but it's really, really limited right now. So we don't have a perfect number or goal, but it's really, based on the needs of the student body and also the capacity of the school district and the community. Okay, so what do we do when the need exceeds the capacity? The first question is we want to ask, can capacity be built, right? Like that's sort of the ultimate goal, is to build the capacity at the local level, to build the capacity of the school, because we want the students to be able to access services inside of their school. We want them to be able to reduce barriers to getting the help that they need. They feel comfortable inside of the school. They are usually attending school anyway, so they can get access to that. And then those school-based clinicians can also support the educators, right? Because, 30 minutes once a week is not where the student spends all of their time. There's other adults that are going to need to help support the student and their mental health. If the school's capacity has been exceeded, that we can also bring in external mental health resources, right? So there are community providers, there are community coalitions that are willing to support. So there's a lot of good resources in the community that can be leveraged. There are, of course, telehealth options. I know, especially for our rural communities, it's not preferred. People really like to be seen in person, especially when we're talking about, sensitive topics and like mental health needs, but it is an option if all other options have been exceeded. And then, of course, there's always the option to refer to a community-based mental health clinician that is not affiliated with the school, but we do really want to try to make sure to bridge that relationship as best as possible. We do have a couple of current extended pilots to help our schools and districts build their capacity. So we have, and I see that Christina Sapien is on, and maybe she would talk about this a little bit at the end, but embedding psychiatry residents onto school district teams. So helping the schools build their capacity to support students with pretty intensive mental health needs. And then also we just recently launched a pediatric access call line, so sort of an on-call line for school clinicians and providers to call into if they are struggling to meet the needs of the students that are on their caseload. But one thing that I do want to say when we think about mental health is there's definitely, there's definitely a time and place for additional supports. Schools can't necessarily do it all. And I think that's an important message, is that, we can do a lot inside of schools. We can bring community clinicians inside of schools. And also sometimes students will need more intensive services, right? So they may need inpatient treatment. They may need community-based treatment. They may need, hospitalization temporarily, right? Like there are sort of extreme cases that will need more support than a school may ever be able to provide, and that's okay. But having the opportunity to engage in so much prevention, we're trying to really reduce the burden on some of those, higher level services, need for higher level services. And then finally, just to sort of, talk about a little bit of alignment with Nevada Medicaid and why this work is important. We've been really working on installing electronic health records. The state has entered into a contract with BH Works. So I believe all of our districts now have the opportunity to use BH Works, which is a electronic health record for schools to track mental health interventions. So that's a really nice new thing that's available. The ability to identify youth early through the use of universal and targeted screeners can help to make sure that we're working towards these mental health systems and getting those good early identification components in place, building capacity and training and coaching on evidence-based practices, supporting the appropriate documentation through the use of those data decision rules and putting that into the electronic health record, and then aggregating and reviewing data with the district and the teams for decision making. So all of this aligns very well with Medicaid, because Medicaid relies on good documentation in order to provide reimbursement. You've got to have these systems in place if you're going to have the opportunity to bill for services. So not all youth will be eligible for billing, but Medicaid has very generously opened up their codes and provided a lot more access for schools to bill. So that's really wonderful and exciting. There's a few references here. I've got additional references should you need them, and I will kind of pause here for some questions or thoughts or just general discussion if anybody has.
Hi, Ashley. This is Regina. I'm with Anthem Blue Cross Medicaid. So I definitely am interested in learning more about some of the pilot programs. I think there's an opportunity for the MCOs to help support or augment what is happening today and continue it. So I don't know, you probably have it on your later slides, contact information, but that would be great.
Yes, there is contact information at the end. Nice to meet you, Regina. Yeah, happy to talk about that. And if you're interested, I'm looking at my friend Christina, who is in the district that is a recipient of some of these services. So if you have specific questions, maybe Christina would be willing to chime in and answer them.
Well, I mean, I don't want to get in the weeds right now for this call. It's being recorded. But Christina, if you could put your information in the chat, I'd love to follow up with you and learn more specifically about the residents.
Sure.
How is it funded? How is it funded? How can the MCOs maybe support more to extend that? What schools are you embedded in? Those are the types of questions that I'm already thinking, like just naturally, right?
Yeah, and we've started out slow just to give you kind of a high level, and they're actually fellows. So they're coming in, and we had Dr. Bennett start about a month or so ago, and Dr. Riss also comes, and they support our DIAT team, our district intervention assistant team, and where we review cases that are high level, difficult, that we need more supports on. So any of our schools can refer to the DIAT team, and it's been great right away. Like we had cases where they were able to jump in and offer suggestions and support. They're also willing on a consultative role to meet with some of our therapists on cases maybe they're struggling with. They're real helpful in the area of, we see, and I'm sure everybody else does too, but a lot of parents that are resistant to medications. Maybe they had a bad experience. Maybe the first med attempt was a bad experience, or they're just not educated, and they may always not be pro medication, and that's fine too. So they would be able to talk to families and support them, answer any questions about any meds, things like that. So we've just started it, and Dr. Bennett will be with us, I think, through June, and then we'll get a new fellow after that. I also, Dr. Greenwald appreciated the explanation of universal screeners, because I think we look at that a lot of times as trying to pull out certain kids, identify certain kids, but I liked your explanation of it, that then maybe we're able to identify a need for that whole classroom or that whole grade level. So I think we forget about that sometimes.
Yeah, that's a great point, Christina. Thank you. And thank you for sharing the feedback on the diet and embedding the fellows. That's really excellent to hear. I'm excited.
We are too.
Great. Yeah, I love it. Thank you. Other questions? Okay, well, thank you all so much for joining me this afternoon. Mara Cruz, I'll hand it back to you.
Thank you. Let's see. Thank you so much for being with us. As a reminder, this session is being recorded. It will be posted on our website, schoolhealth.nv.gov. Our next session will be on June 16th, and the topic will be family communications on school health services, and we hope you'll be there for that discussion.